Hello students, today's topic is very important and very interesting and quite bigger topic. So starting with our knee joint today. So the knee is the largest and most complicated joint in the body. It is a major weight bearing joint in the body. And this joint, because it is a weight bearing joint, it is prone to undergo degenerative changes due to wear and tear. And this results in osteoarthritis. As the age advances, it leads to osteoarthritis. So in the knee joint, if we see the type of joint, we can say it is a modified hinge joint. It is a bicondylar synovial joint. Bicondylar synovial joint, which is present between the femur and tibia, and it allows flexion, extension, and because it is a modified hinge joint also, it allows some degree of medial and lateral rotation of the leg. So what is not true about the knee joint? It is not a true hinge joint. I am saying it is a modified joint, or we can say it is a condylar joint, because its axis of flexion and extension are variable and they are coupled rotation. So it is a modified hinge variety. It also includes the articulation with the patella and femur. So here in this image, this is femur, lower end of femur, tibia, upper end of tibia, and we can also see the largest sesamoid bone, patella. So the femur not only articulates with the tibia, it articulates anteriorly with the patella. So the femoropatellar joint is the saddle joint. So the joint between the femur and patella is saddle joint. Hence consists of three functional compartments. So it is regarded as a compound variety of bicondylar synovial joint. So it is a compound joint. Let's see the articular surfaces. Condyles of the femur articulates with the condyles of tibia. So here these two are the condyles of femur which articulates with the two condyles of tibia. So that is the reason it is called condylar joint. And patellar articulating surface with femur, that is it articulates with the femur to form patellofemoral joint. So this is femoropatellar joint which is present anteriorly. Let's talk about the stability of the joint. Structurally, the knee joint is relatively weak because of incongruence of its articular surfaces. You can see the femoral condyles are quite larger, whereas quite deeper also. Whereas the tibial condyles are too small and shallow to hold the large convex femoral condyles. So that is the reason it is a weaker joint in stability wise. The femoropatellar articulation is also not quite stable because of their shallow articular surfaces and due to the outward angulation between the long axis of the femur and long axis of tibia. So that is also a reason for weak to make the joint as weaker. But still there are factors which maintain the stability of the knee joint. The stability of the knee joint is maintained because of ligaments which are associated with the knee joint called as medial and lateral collateral ligaments which are present on each side of the joint, providing side to side stability. Strength and actions of surrounding muscles and tendons. So there are many muscles and tendons which surrounds the knee joint and protects the knee joint, and there are special ligaments present inside the joint, within the joint, called as cruciate ligaments, which also provides anterior-posterior stability to the knee joint. And the tract which is present on the lateral aspect of the thigh called as iliotibial tract. Iliotibial tract helps in stabilizing in partially flexed knee joint. So these are some of the factors providing the stability to the knee joint. Talk about the ligaments of knee. Starting with the capsule. As any other synovial joint, knee joint also has got capsule. The next other ligaments are ligamentum patella. So this is the posterior view of the knee joint. So ligamentum patella can be seen from the anterior side or lateral side. This is the lateral view of the knee. So this is ligamentum patella, and the medial and lateral collateral ligaments, which are called as tibial and fibular collateral ligaments. So the medial one is the tibial collateral ligament. This is tibia, and here is the condyles of femur. Lateral collateral ligament, which is otherwise called fibular collateral. Fibular collateral ligament. And within the joint, we have got cruciate ligaments called as anterior and posterior cruciate. Cruciate means crossing over. These ligaments cross over within the knee joint. So here the cut part of So we can see the anterior and posterior cruciate ligaments. And within the knee joint, there are a white fibrocartilaginous structures which are called as menisci. So medial and lateral menisci. So medial meniscus and lateral meniscus. The other ligaments which are secondary ligaments protects the knee joint are the oblique popliteal ligament present on the posterior aspect of the knee joint. Arcuate ligament, which is like arching over. So arcuate ligament, transverse ligament, coronary ligaments. So these are the secondary ligaments which are associated with the knee joint. So starting with the capsule. Capsule is thin fibrous sac which surrounds the joint, and it is deficient anteriorly because anteriorly it is replaced by the patella. So we can see. So anteriorly it is deficient because it is replaced by the patella and quadriceps femoris muscle. So here is the tendon of quadriceps femoris muscle, and medial and lateral patellar retinacula, which are also the extensions of this quadriceps femoris muscle, and ligamentum patella. So we can see the ligamentum patella. So these are the anterior structures which makes the capsule deficient anteriorly. Femoral attachment of the capsule, it is attached about half to 1 centimeter beyond the articular margins, where the three special features, like anteriorly it is deficient in the middle, where it is pierced by the suprapatellar bursa anteriorly. Posteriorly it is attached to the intercondylar line, and laterally it encloses the origin of popliteus muscle. You can see. So here is the popliteus muscle which is enclosed within the joint capsule, which continues as the tendon. This is soleal line of tibia. So this is the posterior side of the knee joint, posterior aspect of the knee joint. So we can appreciate the capsule, and we can also see the popliteus muscle cut part of. This is the other end of the popliteus. Cut part of popliteus muscle. So that is about this femoral attachment. And tibial attachment, it attaches to half to 1 centimeter beyond the articular margins, and we know about the ligamentum patella as the special feature. Ligamentum patella, it is actually the tendon of insertion of quadriceps femoris. So we can see the quadriceps femoris which continues via the patella as ligamentum patella. So the ligamentum patella, morphologically it is a part of quadriceps femoris, and patella is the largest sesamoid bone which is developed within the tendon of quadriceps femoris, and this tendon which extends from the apex of the patella to the upper part. So if you see, the ligamentum patella, it extends from the apex of the patella to the upper part of the tibial tuberosity. It is about 7.5 centimeters long and 2.5 centimeters broad, and it is attached above to the rough margins of apex of patella. So above it is attached to the apex. So I am drawing the outline of patella. So this is the apex, and below it attaches to the tibial tuberosity, and it is related to subcutaneous deep infrapatellar bursae and also infrapatellar pad of fat. Moving on to the medial collateral ligament. Medial collateral ligament is otherwise called tibial collateral ligament. It is one of the four major ligaments of knee, and it resists the forces like pushing the knee medially towards the body, and which would otherwise produce the valgus deformity. So if this ligament gets torn, it results in the valgus deformity. So proximally we can see it attaches to the femur. So it attaches to the medial condyle of femur. So we can see here it attaches to the medial condylar femur, and also it attaches to the adductor tubercle on the medial condyle of femur. Below it attaches to the medial surface of the condyle of tibia. So here this is the medial view or medial aspect of knee joint. So where we can appreciate the tibial collateral ligaments and its attachment. It is intimately adherent to the medial meniscus. So internally it is connects to the. So it is closely associated with the medial meniscus. So in cut section from above, this is the superior surface or superior aspect of tibia. This is the medial collateral ligament, or otherwise called tibial collateral ligament, and we can see the medial meniscus here. This is the medial meniscus, which is in close association with the medial collateral ligament. So morphologically, medial collateral ligament represents the degenerated tendon of insertion of adductor magnus. To be more specific, ischial head of adductor magnus. I said proximally medial collateral ligament attaches to the adductor magnus, and adductor magnus muscle inserts, that is the ischial head of adductor magnus muscle inserts to the adductor tubercle. So from the adductor tubercle this ligament continues. So morphologically it is the insertion, that is the continuation of adductor magnus. So this is the medial collateral ligament. Next, about the lateral collateral or fibular ligament. So lateral collateral ligament, as it attaches to the fibula, it represents the degenerated tendon of peroneus longus muscle. So it represents whereas medial collateral adductor magnus muscle. So fibular collateral ligament, the length of it is approximately 5 centimeters and it is a cord-like ligament. Above it is attached to the lateral epicondyle of femur and just above the popliteal groove. So it attaches to the here to the lateral epicondyle of femur. So this is it attaches above to the lateral condyle of femur and below to the lateral side of the head of fibula. So below it is embraced by the tendon of biceps femoris and attached to the head of the fibula in front of its apex. Its deep surface is not adherent to the capsule. So this is the lateral collateral ligament, and it is not directly adherent to the capsule and the lateral meniscus. Instead, the tendon of popliteus, that is the tendon of popliteus muscle, so this tendon separates lateral collateral ligament from the lateral meniscus and the capsule. The lateral meniscus is protected not only by the lateral collateral ligament, that is the tendon of popliteus, and its lower part it is separated from the capsule by inferior lateral genicular nerves and vessels. So medial collateral ligament, if we see, it is much thicker and stronger than the lateral collateral ligament because the knee joint gaps more on the medial side, hence it needs a stronger stabilization on the medial side. Coming to a small clinical aspect here, that is about the knock knee or 𝐒𝐮𝐬𝐜𝐫𝐢𝐛𝐞. It is the condition in which the tibia is bent or twist laterally and the knees are abnormally close to each other, which is called 𝐒𝐮𝐬𝐜𝐫𝐢𝐛𝐞. 𝐒𝐮𝐬𝐜𝐫𝐢𝐛𝐞 is normal in early childhood but can occur with the damage of medial collateral ligament in adults. Then bow leg, that is called 𝐒𝐮𝐬𝐼𝐻, is a condition in which the tibia is bent medially resulting from the collapse of lateral collateral ligament. So moving on to the cruciate ligament. The cruciate ligaments cross each other and attach to the tibia bone with femur and maintain the anterior-posterior stability of knee joint. So further naming as anterior and posterior cruciate ligament with the reference of their attachment with the tibia. So on the tibia. So anterior cruciate ligament attaches to the anterior part of intercondylar area of tibia. Posterior cruciate ligament attaches to the posterior part of the intercondylar area of tibia. So based on tibial attachments, they are named as anterior and posterior. These ligaments invaginate the synovial membrane from posterior side of the knee. So the synovial membrane is almost surrounds the ligaments, but it is reflected posteriorly from the posterior cruciate ligament to the adjoining parts of the capsule. Hence, the cruciate ligament are the intracapsular but extra synovial structures, still lined by the synovial membrane all around except at the posterior part of posterior cruciate ligament, which is devoid of synovial membrane. So, cruciate ligaments are intracapsular and extra synovial. So, starting with the anterior cruciate ligament. So, this is the anterior aspect of the knee after reflecting the patella. So, this is patella. This is ligamentum patellae. So, this is the anterior cruciate ligament. So, anterior cruciate ligament, it is attached to the anterior part of the intercondylar area from the tibia and it runs backwards, upwards, laterally. So, you can remember BUL. Backwards, upwards, laterally, and to get the attachment of posterior medial aspect to the lateral femoral condyle. So, you can see it attaches to the lateral femoral condyle. It prevents the forward slipping of the tibia. So, anterior cruciate ligament mainly prevents the forward sliding of the tibia on the femur and or the posterior dislocation of the femur on tibia and prevents the hyperextension of knee joint. So, this anterior cruciate ligament, it is taut during the extension of the knee joint and it is lax during the flexion. It may be injured in hyperextension injuries. Next, regarding the posterior cruciate ligament. So, this is the posterior view of the knee joint exposing the capsule is removed here, showing the posterior aspect of the knee. This is the posterior cruciate ligament. Posterior cruciate ligament is attached below to the posterior aspect of the intercondylar area of tibia. So, this is the posterior aspect of intercondylar area of tibia. It runs upwards just opposite to the anterior cruciate ligament. It runs forwards, upwards, medially, and it attaches to the anterior part of the lateral surface of medial femoral condyle. So, it attaches to the medial. This is the So, that is the attachment of posterior cruciate ligament. So, posterior cruciate ligament prevents the posterior dislocation of tibia, that is the anterior dislocation of femur over tibia. So, we can say, however, posterior dislocation of tibia or anterior dislocation of femur, and it limits hyperflexion of the knee, and it is taut, it is tensed during the flexion of the knee, and it is lax during the extension. Posterior cruciate ligament splits to form anterolateral and posteromedial bundles, and these bundles are named because of their attachment to the posterior cruciate ligament with femur. These two bundles conjointly inserted into the tibia. Inferiorly, it gets inserted to the tibia. Coming to the anterolateral bundle, it tightens in flexion, while the posteromedial bundle is tightened during extension. So each bundle loosens on the other when the other tightens. Unlike the anterior cruciate ligament, which is not isometric during knee motion. So that is the reason the distance between the attachments varies with the knee position. So Drawers test, this is an interesting test where the anterior Drawers test is forward sliding of the tibia on the femur, and due to the rupture of anterior cruciate ligament. So if there is any anterior cruciate ligament tear, if you pull the tibia out, it slips forward without the posterior, whereas the posterior Drawers sign. So next, after anterior Drawers test, in the posterior Drawers sign is the backward sliding of the tibia. The tibia moves backwards on the femur caused due to the rupture of posterior cruciate ligament. Anterior cruciate ligament is injured more often than the posterior cruciate ligament because the posterior one is thicker and stronger and has two separate bands. The next test associated with these ligaments are Latchman test. Latchman test is carried out at 20 to 30 degrees of knee flexion and is less painful, and it has high sensitivity and specificity as compared with the original anterior Drawers test done at 90 degrees of flexion. So that is about the Latchman's test. Let's talk about the menisci. We know there are two meniscus which are beautifully observed here as the semilunar cartilages. So they are crescentric semilunar cartilages. So I am drawing the outline of the medial meniscus, and here is the lateral meniscus. So the medial meniscus is almost like a half moon, whereas the lateral meniscus is almost a complete circle. So that you have to note down. So these menisci, they are made up of fibrocartilaginous lamina dividing the knee joint into two compartments. So they deepens the tibial condyles. So they increases the congruency of the tibial condyles where the large femoral condyles can accommodate, and also they divide the knee joint into two compartments, upper and lower compartment. So the upper compartment is mainly flexion and extension takes place, whereas the rotation of the knee occurs in the lower compartment. So their peripheral attached borders are thick and convex. So you can see that peripherally they are quite thicker and convex, whereas on the medial side their free inner borders on the inner aspect are thin and concave. Their peripheries are vascularized by the capillary loops from the fibrous capsule and synovial membrane. Because they are made up of cartilage, they are avascular, so they get nutrition from the fibrous capsule and synovial membrane. While the inner regions, the thin parts are less vascular because they are away from the blood vessels. So peripheral tears have the potential to heal satisfactorily on surgical reconstruction, whereas the central meniscal tear rarely heals naturally because of its poor blood supply and are often resected. So if there is any injury, they are often resected because they cannot repair or they cannot heal because of their poor blood supply. The central 1/3 is devoid of any nervous innervation in the menisci. The outer part of the menisci, they are covered by the synovium, so from where it gets nutrition, because synovium is rich in blood supply. So in the beginning, if you remember, I said the secondary ligaments are the coronary ligaments. So now I am going to show where are these coronary ligaments. The tibial attachment of the meniscus is known as coronary ligament, which is otherwise called meniscotibial ligament. So here these are the menisci, both medial and the lateral meniscus. So below that, this is tibia. So here is the anterior aspect after reflecting the patella and the ligamentum patellae. So this attachment So the coronary ligaments are the parts of the fibrous capsule of the knee joint. There are two coronary, medial and lateral coronary ligaments, and they connect the inferior edges of the menisci to the periphery of the tibial plateaus. So along with this, so they connect like this. So connects the menisci to the tibial plateaus. So coming to the medial meniscus, so here is the medial meniscus. So anterior horn of medial meniscus, it is attached to the anterior tibial intercondylar area. This is the anterior horn of medial meniscus. So the posterior is fixed and it attaches to the posterior tibial intercondylar area between the attachment of lateral meniscus and posterior cruciate. So here is the attachment of lateral meniscus, posterior horn of lateral meniscus. This is the posterior cruciate ligament. So in between we see the posterior horn of medial meniscus. So we can remember as LMC. Whereas anteriorly we can remember as M, medial meniscus, then cruciate ligament C, then lateral meniscus MCL. So they are in this order: MCL, Medical College Lucknow, Lucknow Medical College. C stands for cruciate ligaments. This is the anterior cruciate. This is posterior cruciate. M is for the medial meniscus. This is the anterior horn of medial meniscus. This is the posterior horn of medial meniscus. L stands for anterior horn of lateral meniscus, and here the posterior horn of lateral. So they are arranged in this order over the intercondylar area. So the peripheral borders, if you see the medial meniscus, they are attached blends with the fibrous capsule. So lateral meniscus, here this is the lateral meniscus. So anterior horn of lateral meniscus is attached posterior to the anterior cruciate ligament. Posterior horn of lateral meniscus attaches anterior to the posterior horn of medial meniscus. So near the posterior attachment of the lateral meniscus sends an anterior or the posterior meniscofemoral ligaments, which are called Humphrey, or posterior, which is called Rysberg. Anterior is the Humphrey and posterior is the Rysberg. So Humphrey and the Rysberg are the attachments which sends an meniscofemoral ligaments, which are between the meniscus and femoral, attaching the medial femoral condyle, which controls the mobility of the posterior horn along with the popliteus muscle. So lateral meniscus is grooved posterolaterally by the tendon of popliteus muscle. So here I mention, because the popliteus muscle has a protective function by pulling the posterior horn of the lateral meniscus backwards, so that it is not crushed between the articular surfaces. So such a tendon is not there on the medial meniscus. That is the reason medial meniscal tear is more common than the lateral meniscus. Now let us discuss about these meniscal tears. The injury of the menisci are commonly caused by the twisting strains or slightly flexed knee or in the kicking a football. So all these are the reasons for the meniscal tears. So the meniscus may get separated from the capsule or it may be torn longitudinally, which is called as bucket handle tear or transverse tear. The medial meniscus is more prone to injury than the lateral of its firm fixity, because the medial is more firm to the tibial collateral ligament and greater exertion during the rotatory movements. So one thing we can note here, pain on the medial rotation of tibia on the femur indicates the injury of medial meniscus, while pain on the lateral rotation of tibia on the femur indicates the injury of lateral meniscus. So let's start with the discussing about secondary ligaments. So the secondary ligaments, which we already mentioned about this oblique popliteal ligament, it is an expansion from the tendon of semimembranosus muscle. So oblique popliteal is morphologically it is semimembranosus muscle, and it runs upwards laterally superficial to the capsule, and it is attached to the intercondylar area of femur. So this one is the oblique popliteal ligament, which is present on the posterior aspect of the knee joint. So it blends with the capsule of the knee, and it is pierced by middle genicular vessels, middle genicular nerve, and posterior division of obturator nerve. This thing you have to note down. Let us discuss about the next secondary ligament called as arcuate popliteal ligament. So here is the arcuate popliteal ligament, which attaches to the fibula here. So it is like letter Y. You can see the stem of the Y attaches to the styloid process of fibula. So this is arcuate popliteal ligament. So the large posterior limb band arches over the tendon of popliteus. So you can see here, this is the tendon of popliteus muscle. So it is the tendon. So we can see this part arches over the tendon of popliteus. That is the posterior band of arcuate ligament, and it is attached to the posterior border of intercondylar area of tibia. The small anterior limb, it is often deficient and passes to the fibular collateral ligament. So that is about the arcuate ligament. So the next accessory ligament is the transverse ligament. So transverse ligament, it extends transversely, connects the anterior end of the medial and lateral menisci. So this is the anterior end of medial meniscus, this is the anterior end of lateral meniscus, which are connected by the transverse ligament. It is present only in 40% of individuals. So the last secondary ligaments are the coronary ligaments, which I have already discussed, that these coronary ligaments connects the menisci with the tibia. So they connects the menisci, the lateral and the medial meniscus with the tibia. So they provide peripheral attachments along the peripheral margins of the medial and lateral menisci of tibia. And as we mentioned earlier, the coronary ligaments are two medial and lateral coronary ligaments. So at this point we can discuss one clinical aspect, which is called as unhappy triad, Odonoc triad. It is the triad which is associated with the knee joint. It may occur in the footballer players commonly. It is because the footballer's shoe, it is firmly in the grass and the knee is stuck from the lateral side. So the mechanism of injury is the foot is fixed down over the ground and knee is flexed, twisting and also twisted while during the fall, causing a fall also. So this is characterized by the rupture of tibial collateral ligament and due to excessive abduction, tearing of anterior cruciate ligament as a result of forward displacement of tibia, and injury to the medial meniscus as a result of tibial collateral ligament. So three structures are involved in unhappy triad, which is very common with the football players. Moving on to the relations of the knee joint. Anteriorly, knee joint is related to ligamentum patella and patellar plexus. Posteriorly, it is related to popliteal artery, popliteal vein means popliteal vessels, tibial and common peroneal nerve, medial and lateral head of gastrocnemius plantaris. Medially, it is related to You can remember the short form SGSS. So S stands for sartorius, G for gracilis, again S for semitendinosus. All three are gyrops muscles, and it is also related to semimembranosus. And apart from these four muscles, it is medially, the knee joint is related to great saphenous vein and saphenous nerve, and it is related to inferior medial genicular vessels and nerve which supply the knee joint. Laterally, the knee joint is related to biceps femoris before its insertion to the head of the fibula, and it is related to the popliteus. We already shown the popliteus muscle along the lateral meniscus, it is present, and it is also laterally related to inferior lateral genicular vessels and nerve which supply the knee joint. Let's discuss the bursa around the knee joint. There are around 12 bursae around the knee. 4 are present in the anterior side, 3 are lateral, 3 are medial, and 2 are on posterior aspect. So let's talk about the anterior bursae. Anterior bursa, the first one is the subcutaneous prepatellar bursa, so which is called as housemaid's knee, the bursa of housemaid's knee. It lies deep to the skin in front of the lower half of the patella and upper half of the ligamentum patella and tibial tuberosity. Next bursa is the subcutaneous infrapatellar bursa, which is present between the skin and smooth part of tibial tuberosity. The third is the deep infrapatellar bursa, which is present between the ligamentum patella and tibial tuberosity. Suprapatellar bursa, which is between the anterior surface of the lower part of the femur and deep surface of the quadriceps femoris. So these are all the anterior bursae. Now moving on to posterior bursae. The bursa which is between the lateral head of the gastrocnemius and the capsule of the knee joint, that is on posterior aspect, and one more bursa, the bursa between the medial head of the gastrocnemius and the capsule of knee joint, which is called as Brodie's bursa. Let us discuss about the lateral side. So the lateral bursae are the bursa between the fibular collateral ligament and tendon of biceps femoris, which is called lateral collateral bursa, and bursa between the fibular collateral ligament and tendon of popliteus, that is one more lateral bursa, and the third one is the bursa between the tendon of popliteus and lateral condyle of femur. This bursa is really a synovial tube around the tendon of popliteus, hence it communicates with the joint cavity. So we've completed with anterior, posterior and lateral. So let's do the last one, that is the medial bursae. Medial bursae, these bursae which separates the tendon of sartorius, gracilis, semitendinosus. These three muscles are inserted to the upper part of the medial part of the shaft of tibia, medial surface of shaft of tibia, it gets inserted. So these three muscles together called as gyrops muscles. These three tendons are separated by a bursa which is called as 𝗑𝐵𝐴 because it appears to be like a foot of a goose, which is called as 𝗑𝐵𝐴 or because it is invests along the tibial collateral ligament and these three tendons. So the bursa between the tendon of semimembranosus and medial collateral ligament, one more bursa is present, and the bursa between the tendon of semimembranosus and the medial condyle of tibia. It may communicate with the knee joint sometimes. Coming to the applied anatomy or clinical correlation associated with these bursae, housemaid's knee, it is the inflammation of prepatellar bursa which is called prepatellar bursitis. It occurs due to the friction of the bursa against the patella when it comes in contact with the ground during scrubbing of the floor by housemaid. So such a bursa may get very enlarged, enlarged and drop by its weight to much below the original position. The next condition is 𝐒𝐻𝐺𝐻𝐿 knee. It is the inflammation of subcutaneous infrapatellar bursa which is called as 𝐒𝐻𝐺𝐻𝐿 knee, subcutaneous infrapatellar bursitis. It occurs due to the friction of bursa against the tibial tuberosity due to kneeling. So kneeling during prayer, especially the Christian priest, So it is called 𝐒𝐻𝐵𝐻. So that is the reason it is called 𝐒𝐻𝐵𝐻𝐼n's knee. Next one is the popliteal cyst or Baker's cyst. The chronic inflammation of bursa due to the semimembranosus may present a cystic swelling on the medial part of the popliteal fossa, which is called as Baker's cyst or popliteal cyst. So this completes the clinical correlation. Let us complete the knee joint with its blood supply also. So the knee joint is richly supplied by the blood through arterial anastomosis around the knee. So there are 5 genicular branches of the popliteal artery which supply the knee joint. So the descending genicular branch of femoral artery, descending branch of lateral circumflex femoral artery, and 2 recurrent branches of anterior tibial artery and circumflex fibular branch of posterior tibial artery. So all these arteries will anastomose with each other to form anastomose around the knee joint. So superior medial genicular artery anastomoses with the descending genicular branch of femoral artery, and also it anastomoses with the inferior medial genicular artery. Next, about the inferior medial genicular artery, anastomoses with the superior medial genicular artery and also with the saphenous artery. Saphenous artery is a branch of descending genicular artery, which is in turn a branch of femoral artery. Superior lateral genicular artery anastomoses with the descending branch of lateral circumflex femoral artery and inferior lateral genicular artery. The other anastomosis is inferior lateral genicular artery anastomoses with the superior lateral genicular artery, anterior and posterior recurrent branches of anterior tibial artery, and also the circumflex fibular branch of posterior tibial artery. So all these completes the anastomosis around the knee joint which supply the knee joint. And let's wind up with the nerve supply. The knee joint has the nerve supplied by femoral nerve through the branch of vastus medialis, tibial nerve and common peroneal nerves through their branches of genicular branches, and obturator nerve through its posterior division. So let's discuss about the muscles producing the movements of the knee joint. So the range of movement of knee flexion is around 130 degrees, whereas the range of extension is around 0 to 50 degrees. So the range of motion of flexion is greater when the hip joint is fixed, and the range of movement of extension is greater when the hip joint is extended, and limited when the hip is flexed. So let's talk about the movements and main muscles and accessory muscles causing these movements. Flexion at the knee, it is brought by the biceps femoris, semitendinosus, semimembranosus. All 3 are the hamstring muscles. And accessory muscles are gracilis, sartorius and popliteus. Extension of the knee is mainly brought by the quadriceps femoris, and accessory muscle is TFL, tensor fascia lata. Medial rotation of the knee, that is the flexed leg, is by popliteus, semitendinosus and semimembranosus. Accessory muscles are sartorius and gracilis. Lateral rotation is by biceps femoris because it is present on the lateral side. So let us discuss some important and interesting feature of the knee, which is called as locking and unlocking of the knee joint. Locking of the knee, when foot is fixed on the ground on conjunct the medial rotation of the femur. So the femur rotates medially over the tibia in the last stages of extension, that is last 15 degrees of extension, which is called as locking. It is a part of locking mechanism, and it is like a so-called screw home movement, and which is an asset when fully extended knee are subjected to the strain. So full extension results in the closed pack position, which is of maximal spiralization, means maximum rotation. The tightening of the ligaments happens during the locking, and locking of the knee joint involves the lateral rotation of the tibia. So lateral rotation of the tibia and medial rotation of femur, that is locking. So if the foot is not fixed to the ground and is free in the air, so that is when the tibia moves when the foot is free in the air. So when the foot is on the ground, the locking is defined as medial rotation of femur on the tibia during terminal phase of extension of the knee. Locking is carried out by quadriceps femoris. So we discussed till now about the locking. Moving on to unlocking of the knee joint. So at the beginning of the flexion, so from full extension, the initial part of the flexion with the foot fixed, where the lateral femoral condyle, that is the lateral femoral rotation occurs, which unlocks the knee joint. So the unlocking is carried about by popliteus. That is the reason popliteus is called as key muscle of knee joint. So here, when the knee is unlocked, it can be further flexed by hamstring muscles. So locking of the knee is essential for bearing the load during erect posture. The locked joint must be unlocked to facilitate progression of locomotion, that is to facilitate further flexion. So during walking, locking and unlocking of the knee takes place alternatively and rhythmically. So this is about locking and unlocking of the knee. I hope you understood this concept. So moving on to some last clinical aspect, that is about osteoarthritis of the knee joint, because knee joint is the weight bearing joint and knee joint is commonly involved in osteoarthritis, that is degenerative wear and tear of articular cartilages. So the movements are may be painful, limited, and they produce grating action. So in radiographs, the knee joint reveals, if there is an osteoarthritis, it reveals the osteophytes, means small bony nodule like structures within the joint space. And joint space also reduces in osteoarthritis and resulting in peripheral lipping of the articular ends. And arthroscopy of the knee joint means it is an endoscopic visualization of the knee joint to see the interior of the knee joint cavity with minimal disruption of the tissue. So the ligament repair or replacement can be performed by using arthroscope. So points to remember in the knee. So we are now to summarize. So knee is the largest synovial joint in the body. Rectus femoris, vastae muscles are for the knee extension, means quadriceps femoris causes knee extension. Knee flexion is carried out by hamstring muscles. And anterior cruciate, posterior cruciate ligaments are intracapsular, extrasynovial. They lie inside the joint capsule but outside the synovial cavity and still covered by the synovial membrane. And a torn portion of the meniscus may sometimes displace and become jammed between the tibia and femur in the center of the joint, which is called as bucket handle tear. And this may cause due to blocking of extension, locking of the knee. So this completes the clinical aspect of the knee joint, and we completed all the anatomy of the knee joint, including each and every ligament associated with the knee joint. Thank you.